Hello friends, my name is Savinder Virk, and today I'm going to be presenting a patient whose age we're going to round off to 40 years. He's an African-American male, weighs about 200 pounds with a 6 foot 3 inches of height, giving him a normal BMI, a healthy BMI. He's here because he has diabetes type 2, and he had complained of his blood sugar levels been running high lately. He was diagnosed about 2 years ago at the same clinic. He's been a patient here for almost 3 or 4 years, and he reports taking his medications on time. He said that for some strange reason, despite his diet being regulated and he maintains some exercise level, his blood sugar levels have been consistently going high for the past 1 month. He was diagnosed, like I said, 2 years ago, and we also diagnosed him with hyperlipidemia at that time. He said he has he has cut out red meat from his diet completely, and that he really watches what he eats in order to prevent any type of heart disease. He has surgical history of appendectomy in 2009 and tonsillectomy at age 16. Besides that, no past medical history. He reported that about 3 months ago, he fell at his work. He works as a pharmacist at Walgreens, and he is seeing a pain management doctor for his back pain. He has had a lumbosacral sprain. I think that's what it is. And he's currently having physical therapy for that, but a pain management doctor is managing that. No childhood diseases. No childhood diseases reported, and immunizations are up to date. Flu shot was received a couple of weeks ago. He takes lovastatin for his cholesterol, 20 milligrams at bedtime, metformin 500 milligrams twice daily with food, because he said it tends to upset his stomach, and tramadol 50 milligrams every 6 hours as needed for pain. Patient reports being allergic to penicillin. He is married and lives with his spouse in a one single-story house. He has 2 teenagers and 2 children who attend middle school. He's been on disability for the past 1.5 months due to back injury. Despite that, he said he continues to walk 15 minutes every day and 4 times a week. He's volunteers at his fire station most of the time, but he hasn't been able to do that because of his disability. But he does attend weekly, every Sunday after church. He attends a book club with his friends. No illegal drug use reported. Reports about 1 to 2 drinks at a party. No tobacco use reported. Parents are fairly healthy. Mother is alive. No health problems. Father has diabetes, but he was diagnosed in age 55. Older brother has high blood pressure, and middle sister has diabetes, and she's had it for the past 2 years at age 45. So like I said, he reports that diabetes is a family problem and has been run on his paternal side for a long time. He does not know any history of his grandparents. He denied any fever, sweat, chills. A generally review of systems was pretty good. No signs of any problem seen within the skin, hair, and nails. General was good. He said his last vision test was 2 months ago, and his vision is 20/25, and he has no hearing problems. Last hearing test was 3 years ago. Denies any chest pain, lung problems, asthma, no cardiovascular issues, no abdominal, GIGU, musculoskeletal, just the lumbosacral pain, and he's taking pain medication for that. No numbness, tingling, no history of anxiety or depression reported. Vital signs were pretty stable. 115/73 for blood pressure, pulse was 74, respiration 16, temperature 98.9. So like I said, his BMI was 25.0, but his fasting blood glucose level was 295. So when we did a physical assessment on this patient, he was a reliable historian, wearing weather appropriate clothes, skin and hair were fine, average for his ethnicity. No dryness, no alopecia, no infestations, no exposed skin, nothing, rashes seen. Head was normocephalic, no enlarged lymph nodes or masses that were noticed. Trachea was midline, pupil, perla, no strabismus, disc margin. I did check his eyes because he has diabetes, and because of his age, just want to rule out any macular degeneration. That's what it was. And because with diabetes, the vessels that come to the eyes or to the peripheral regions of the body, like the feet or the hands, and this is why you'll see a lot of neuropathy in diabetic patients. It's because those small vessels tend to get crystallized with patients who have diabetes, and in their kidneys as well, which is why they're more which is why physicians or nurse practitioners are asked to focus on those patients and that certain body part, because it crystallizes and it breaks off the blood vessel, hence delaying blood and nutrients and oxygen to that area, basically causing a ischemia. Today my words are really failing me, but basically causing ischemia to that eye. So when we did exam of his eye, bilateral vision fields full with confrontation, strabismus and nystagmus was negative, disc margin sharp without any hemorrhages or exudates, no anterior narrowing, conjunctiva was pink and sclera was white. His acuity was good to a whispered voice. Tympanic membrane was pearly white and intact with no redness or bulging. Cone of light visible bilaterally, 5 o'clock on the right, 7 on the left. Turbinates intact, nares, patent, septum, midline, no nasal flaring or discharge. Basically, he had no trouble with his cardio or his respiratory. Had carotid upstrokes, brisk with no bruise, no JVD present, PMI palpable at the 5th ICS, and no pain elicited with chest wall inspection or palpitation. Normal active bowel sounds, no CVA tenderness, kidneys not felt, no flank pain, border of the liver was located, but I didn't see any swelling. A spleen was not palpable. Like I mentioned, lymph nodes were not enlarged. His extremities, which is another important part about diabetic patients, you need to make sure they are warm to the touch, that the patient actually can feel the pinpoint. And at this point, I did take a small pin and I checked each and every one of his fingers and then his toes and across his foot to make sure that he did feel some sensation, and he actually felt soft from pain. So basically checking his neurofunction to make sure that everything is still well intact. Alert and oriented ⅓, cranial nerves were intact, normal gait, reflexes were 2+ and symmetric. So musculoskeletal, we had a little bit of issue because he does have back pain. So he had a normal gait, tenderness with range of motion on flexion, extension, lateral bending, right rotation, and left rotation. So just palpable muscle spasm in lumbosacral area, so which he reported to us that he has a lumbosacral sprain. His monofilament test to the right and left grade 2 and metatarsals on feet was good. It was positive. Okay, so I diagnosed him with uncontrolled diabetes mellitus. And as we know, diabetes is a disease that consists of an array of dysfunctions, which are hyperglycemia, cause excessive thirst, hunger, sweating, and it can be caused by a majority of reasons, but the major reason is insufficient insulin secretion, or just the body becoming insulin resistant. It also can be caused by an autoimmune disorder in which beta cells destroy them, but that is diabetes part 1. So basically, you want to see if your patient ever walked in with high blood sugar and blurred vision, send them off to the ER. If they ever walk in with a headache and blurred vision, send them off to the ER. low extremity paresthesis, yeast infections, which is basically called bellinitis in men. If the patient comes in and he's a male and he reports reoccurring yeast infections, you might want to check for diabetes as well. In men, you will see a lot of weight loss instead of weight gain unless they are really bad about their diet. So, differential diagnosis was metabolic syndrome, a group of factors that can be linked to insulin resistant and cause hyperlipidemia. In our patient, he does have metabolic syndrome because he does have hyperlipidemia, and he also has uncontrolled diabetes. But for this visit, it was uncontrolled diabetes that we were focused on. His lipid levels were actually fine from his lab tests a month ago. Hyperthyroidism, overactiveness of the thyroid gland, can also cause stress-like factors in the body, causing the blood sugar to elevate. So I'm attaching a copy of the SOAP note so everybody can see. His previous labs were actually done on 10/29. So his HbA1c was 7.5, which is slightly elevated. Triglycerides were 181. Total cholesterol was 132. HDL was 54. And LDL was 96. And patient self-reported blood sugar levels for the last month between 201 and 300, and this is fasting, first thing in the morning. So what we did do to manage this, we were going to check his vitamin B12 levels and vitamin D level just to make sure. Sometimes when especially since the patient is reporting higher blood sugar levels, fatigue is one of those things that can be caused by vitamin C deficiency, and when we're fatigued, it takes our body more effort to produce more to get the right amount of sugar in the right places, and that can also cause for elevated or spiked blood sugar levels every day. And as for the HbA1c, despite the fact that there is a lot of research that says that the patient could have in the last 3 months, what is the patient's blood sugar level? So my question is, what if this patient in the last 3 months has been attending a lot, or is a wedding planner, or has been attending a lot of wedding or family ceremonies or that, and has ate a lot of sugar there? So the HbA1c would actually not be accurate at that point. I am actually currently studying a research paper to make sure that, my facts are concurrent with what the new research is. I recommended diet and lifestyle changes to him, and I told him we needed to repeat his HbA1c next month to make sure that, even though it's done every 3 months, I wanted to start him on new medication and wanted to check back if the medication was actually working for him. So diet and lifestyle changes are important in the management of diabetes. Even though his weight and everything is at a good level and his BMI is good, we would still encourage him to continue with the therapeutic lifestyle. Check feet daily. In fact, even put in a recommendation for a podiatrist. It is never too soon and is never too late for late, yes, but never too soon for a diabetes patient to have a podiatrist, because neuropathy is one of those things that creeps up on a patient, and by the time we figure out the patient does start having foot ulcers, or they stop noticing that something is wrong with their hands or their feet. He's very compliant, according to him, with his diet, but stress, and we try to talk to him about his stress level and about the fact that he has 2 teenagers in school. Maybe that is what's causing his stress. He said he realizes that he has stress, but he says he doesn't feel it on his body, but apparently it's showing up as higher blood sugar levels. So with addition to the metformin, that's 500 milligrams, we have changed the metformin from metformin regular to metformin ER, the extended release, so that it will be more comfortable on his stomach and it would last longer in his body as well. So we also added glimepiride 2 milligrams twice daily. Glimepiride is a medication that is given to patients to initially lower their blood glucose, even though metformin is initial blood glucose lowering medication. The 10-year risk for a patient who has hyperlipidemia and has diabetes is higher for stroke or cardiovascular disease. That's why a combination medication is used so that the patient's blood sugar levels can be brought within control, and the diabetes does not damage their vital organs. Follow-up appointment would be made for within the next 6 weeks. Because we need some time for the medication to kick in, the patient has been given instructions if there's a rash or if he breaks out to go to the nearest emergency room, as well as a report to the PCP or the nurse practitioner if something has occurred, or if there is an adverse reaction, to call 911 immediately. Pain medication and cholesterol medicine should be the cholesterol medicine should be taken as directed, and the pain medicine should be taken as given directions by the pain management doctor. So I'm also attaching the copy of the SOAP note so that everybody can see it. The basic standard procedure has already been followed for this patient. The standardized procedure for a patient that comes in with diabetes, that comes in with high blood sugar levels, is basically to check the blood sugar levels. This is a returning patient. If this was a new patient, it is basically to check the blood fasting glucose over the next over the week and a half. 3 consecutive high levels of blood sugars is sufficient to give the patient a diagnosis of diabetes, but you also want to check for the HbA1c. What is also recommended is that if the patient's blood sugar level is 295 on fasting, patient needs to be started on metformin, or doctor needs to further investigate about more history of what the patient has been eating within the past 72 hours to come to a conclusion. But for 3 consecutive readings of high blood sugar, the patient should definitely be given the diagnosis of diabetes, and metformin is first-line agent. Well, diet and exercise is first-line agent, but metformin is also first-line agent for diabetes control. Well, I hope you guys found this informative. If you have anything to add, please let me know. Looking forward to hearing your comments. Thank you.